كده أحسن.
ايوه اهلا. سامعني؟ Okay, thank you very much. Good evening, all of you. I want to welcome all colleagues who are seeing us now in our second webinar, and I hope we can present them a very good scientific stuff on Erbs Palsy. First, I want to thank the company Novartis for the great support of us to make this webinar possible. And I want to thank all participants, Dr. Simon Lambert, Dr. Ayman Mansour, Sharif Amin, Yasser Safuri, and Alex Mousset. And unfortunately, I want to send a message to Dr. Alex in the name of the Shoulder Society and all of us. We are praying for him to recover quickly from his problems. And we all wish him a quick recovery and coming back to his scientific activity with us and with his patients and with the International Medical Society. I give the word to Dr. Ayman Mansour, who is going to moderate this webinar. I thank him very much for that. Please, Dr. Ayman. Hello.
Good afternoon, everybody.
Good afternoon.
الصوت واضح كويس والصورة كويسة. بس الكاميرا بتقطع عندي معرفش. هو في حاجة أنا عندي الفيديو الكاميرا بتقفل لوحدها معرفش ليه. طيب ما علينا. أنا عندي مشكلة يعني الكاميرا بتقفل لوحدها.
I think we can start till the problem with Dr. Ayman is solved with the first presentation from Dr. Yasser. Dr. Yasser Safuri. Dr. Yasser, you hear us? I think Dr. Yasser.
Assalamu alaikum wa rahmatullah. Good evening, everybody, and welcome to the second webinar of the Egyptian Shoulder Society Association. I'm Ayman Mansour. Tonight's webinar will be focusing on the shoulder problem in Erbs Palsy and its management and how to solve this problem. I would like to introduce today's speaker, Dr. Bassem Flega. He's the famous shoulder surgeon, and he's the president of the Egyptian Society Association of Shoulder Surgery. Dr. Yasser Safuri is a professor of orthopedic surgery. He's the coach now for the Department of Hand and Upper Limb Surgery at Al Qasr Al Aini University. Dr. Sharif Amin, professor of orthopedic surgery, and he's our mentor and our master. He's a very eminent upper limb surgeon. Dr. Simon Lambert, he's a friend of us from the AO trauma chapter here in Egypt. He's an eminent shoulder surgeon and always had a very fascinating lecture about shoulder biomechanics. Unfortunately, there was also Dr. Alex Musi from Spain, but he's under quarantine because he got the coronavirus and he cannot be with us today. We wish for him a speedy recovery. We'll start today's meeting by Dr. Yasser Safuri. Yes, Dr. Yasser, good afternoon. Good evening, sorry.
Good afternoon, Ayman.
Yes, thank you. Can you start with your presentation? Thank you.
Okay, this presentation will be on the clinical pictures which we meet in Erbs Palsy and how can we think in treatment of these patients. So the incidence varies from one country to another. It may reach 3 cases per 1,000. In Egypt, we don't have specific incidents, but we as a society are working with the government so that we can study this incidence. Fortunately enough, most of the cases will recover, and this presents about 60% of these cases which recover. The cause, as we know, may be a problem during delivery as a big child or in his position. So there is traction and injury of the brachial plexus. Very early, we found this picture, which is called policeman tip deformity. The shoulder is adducted, no flexion of the elbow, and slight flexion of the wrist. In older age, if he comes to you, then he has a problem in the overhead elevation and the elbow flexion. So what is the pathology? During delivery, there may be traction of the nerve. This is known as neopraxia, and then it recovers. Or there may be avulsion from the cord or rupture, post-ganglionic. Sometimes there is some healing and some progression of the nerve. This is called neuroma in continuity, which gives a picture which is known as co-contraction later on, and there is spasm of the muscles of different groups. We use the classification of Narakas, which divides brachial plexus injuries in upper, Erbs Palsy, which will be the topic of this webinar. Then we have extension to C7, intermediate, or global or complete rupture of the whole brachial plexus. Sometimes it's selective, taking C8, T1, and there's a problem in the hand. The anatomy is complex, beginning from the anatomy of the approach. So we have the carotid sheath, we have the subclavian artery, pleura, phrenic nerve. The surgeon should be very familiar with the approach and the anatomy of this area. And there is a learning curve. As regards the topography of the nerve, also it's complex. So different peripheral nerves may have different routes. This is a diagram, which is very informative, how to think of the root and the peripheral nerve. So in Erbs palsy, what is affected is the shoulder and the elbow. So there's injury of the suprascapular nerve, the musculoskeletal nerve, and maybe a part of the axillary nerve. If you look at this slide over here, if there is an injury here in the trunk of the C5-6, the trunk, then you lose the suprascapular nerve completely, and you lose the musculoskeletal nerve. At the same time, there are contributing branches which give the axillary nerve, giving the deltoid. So you can have a weak deltoid. And there are certain muscles directly communicating with C5-6, which is the extensor carpioidalis longus, supinator brachioradialis. But you should understand that although there's injury of the upper trunk, the contributing branch to the median nerve from the lateral cord still has some contributing branches from C7 coming to it. That's why you have a good flexor carpioidalis and a good pronator teres. If you understand this type of diagram, then you know why do they have the mismatch tip deformed? Why do they have loss of the shoulder, elbow, and at the same time there is pronation and slight flexion of the wrist? This is the picture, and this is the classification which you use, which is called Erbs palsy. Okay, what are the pictures which you meet? You can find in your clinic a patient coming to you at an age of 3 to 6 months. What does he have? He may have loss of the elbow movements and the shoulder. And they come to you for your advice. This is the time of microsurgery, from 3 to 6 months, no biceps. Then we transfer the patient to the OR to do him microsurgery. But if there is a recovery of the biceps, but there's no recovery of the shoulder, we wait until 9 months. Here, we can enhance the recovery of the shoulder by nerve transfer directly of the suprascapular nerve to the spinal accessory. This is controversial. Some other doctors follow up the patient, guard against contractions, and later on prepare him for muscle transfer. If you get an older child coming to your clinic at 2 to 4 years old with no contractions and has no overhead elevation, then you can advise for muscle transfer. But if there are contractions, you cannot do muscle transfer alone. Then you can go for releases. But if he comes older with no bony deformities and contractures, you can treat him the same, as long as there are no bony changes in the head or the glenoid. At an older age with bone changes, then you need bony correction. Each one of these procedures of microsurgery, muscle transfer, bony deformities will be discussed in this webinar with very eminent professors. There are different techniques which we use. We use microsurgery. Dr. Sharif Amin will be talking about this technique. Or nerve transfers, as I mentioned before, in some cases. Subscapularis release, alone or with muscle transfer, and even it can be done with arthroscopy, and will be discussed. and humeral osteotomies or glenoid osteotomies according to the picture which we discussed with Dr. Samuels. So a patient coming like this in 3 to 6 months with no biceps, no shoulder, this is a candidate of microsurgery. If he is recovering from the elbow, you should look to the shoulder. If there is no recovery of the shoulder, you should think of nerve transfer or guard against contractures until there is recovery of the shoulder. Or he will be a candidate of muscle transfer later on. What do? We do microsurgery by nerve grafts, will be discussed by Dr. Shrif. This is a technique. What about this patient? It's also a patient presenting at 6 months with this type of deformity. This was an Erbs Palsy, but was transferred to physiotherapy. We believe that physiotherapy alone will recover the patient, and he was so aggressive that he forced the shoulder into dislocation and anterior dislocation. So the patient now has 2 problems, has obstetric brachial plexus and anterior shoulder dislocation. An older child coming with 2 to 4 years old and has weak overhead elevation, and the patient's coming to you to help this patient, you should see if there is weak deltoid or not, or if there is no contraction or unsupple joint, or there is stiffness and contracted joint in adduction and internal rotation. As I said before, now we understand why in some patients there are weak deltoid and others there is good deltoid. This depends upon the axillary nerve contributing branches. It comes from other nerves. So if there's injury of a part of it, it's weak. If the axillary nerve, there's some recovery and contributing branches from other roots, then you have no deltoid weakness. So it's about the deltoid and the abduction power which he has before the operation. If he has, like this patient, good deltoid and has this trumpet sign, the muscle transfer here gives very good results. But in this patient, she has weak abduction, weak deltoid. She will improve with muscle transfer, but the results are less than those with good abduction. Muscle transfer will be covered in the common literature. We use several muscles like the latissimus or the teres major. But a point here which I want to clarify is that the latissimus dorsi muscle is the key. Because as you see here, it has different roots contributing to this peripheral nerve going to the latissimus dorsi. So it's the key which you can use in different pathologies and in different types of Erbs Palsy. But if there is an old child with deformity of the head and the hypoplastic glenoid coming to you, is there an option for surgery here? This will be discussed later. But it's not in all types of patients and all patients that they have a bad head or deformed head. Sometimes, because of the physiotherapy program, these patients do have a minimal changes in the head, and muscle transfer here can be very suitable for them. But there are certain special situations which you can face and needs a little bit of thinking. Is that a patient coming to you after doing microsurgery? Can you help him and he has weak overhead elevation? Or a patient already did a derotation osteotomy, but he is complaining that has no good function. Can you help this patient? So like this patient, after microsurgery, she has weak overhead elevation. Or this patient which has had an internal rotation deformity corrected by osteotomy, but a weak overhead elevation. We'll answer this question in the following presentation. So the strategy depends upon the age of presentation, the muscle power you have, any contractures, and bony changes. Thank you very much.
Okay.
Thank you, Dr. Yasser, for the nice presentation, short and to the point. Now we'll go to Dr. Sharif Amin. He will tell us about microsurgery role in treatment of Erbs Palsy. Thank you, Dr. Sharif. Dr. Sharif.
Yes.
Yes. Can you please tell us about the microsurgery in the Erbs Palsy? What's the role and its usage?
Very well. Now, microsurgery, as Dr. Yasser has mentioned, next please. The microsurgery, as Dr. Yasser has mentioned, is about exploration of the brachial plexus, and this must be done during the first year of life, preferably the younger age, the better. The indications are which patient would benefit from such intervention. We have broadly two main types: the upper plexus injuries with absence of recovery of active elbow flexion by 3 months of age. This is one indication. Or in the complete injury with surgery done at 3 to 4 months of age, and this is to have an easier anesthesia and surgery. Despite that, the fact that we know that such babies with complete injury would certainly have surgery. Next, please. The position. Now we're talking microsurgery is, in general, in brief, after exploring of the plexus properly, definition of where are the damaged part, excision of the damaged part, and then bridging with grafts from the sural nerve, mostly this defect, plus using nerve transfer if this connection is not enough. So I would concentrate on this presentation on the fact that such a surgery needs to be done carefully, and for one to do careful surgery, one should be familiar with the landmarks. So we start by position. We put a sandbag under the ipsilateral scapula with the head turned to the other direction. Next, please. This extends the spine and makes the field easier. The incision is that is commonly used is a classic L-shaped incision following the posterior border of the sternomastoid, then along the superior border of the clavicle. This allows the extension to be prolonged along the deltopectoral interval if exploration of the infraclavicular plexus is needed. Next, please. And then under the skin, immediately we find the platysma. And immediately under the platysma, we find the supraclavicular nerves. The supraclavicular nerves could be very, very fine. If possible, one can preserve them, and if not, one should cut them a little high so as not to make a neuroma. Isolation and ligation of the external jugular vein is frequently needed as it comes into the way. And then going a bit down, we will go over the prevertebral fascia. We have the lymph nodes, and among the lymph nodes, there is the transverse cervical and the suprascapular vessels. They should be identified, ligated, and cut in order not to provoke any bleeding. And then one finds the omohyoid, cut it in the tendinous part between the two heads. The omohyoid leads one very easily to suprasternal notch where the suprascapular nerve is found. The lymph nodes and the fat in the posterior triangle are retracted laterally away from the posterior border of the sternomastoid to expose the prevertebral fascia that is covering the plexus. And then, next, retractors on the medial side should not go beyond the medial border of the scalenus anterior. retraction should be gentle. And because beyond this line, there is the carotid sheath with all the important contents. And then we start the condition by identification of the phrenic nerve on the anterior surface of the scalenus anterior between the muscle and the fascia, heading from above downwards, from lateral to medial. This is when this is done, one can trace the phrenic nerve to the level of the C5 root, which is located where the phrenic nerve lies on the lateral border of the scalenus anterior. When one finds C5, one goes a little bit down opposite the lower foramen, C6 and C7 under C5 under the corresponding foramina. Next. And then exposure of the lower trunk and its roots necessitates clavicular osteotomy. Clavicular osteotomy is done carefully, and then the lower trunk is identified behind the clavicle next to the pulsations of the subclavian artery, because the artery and the lower trunk, they resemble each other, and only the pulsations makes the difference. And one feels it to be sure that this is the nerve, and this is the artery, and one finds immediately next to it the lower trunk. And then one can, exposure of the plexus distal to the neuroma starts by identification of the pulsation of the axillary artery. You always find identification of the artery in order not to make mistakes by inadvertently cutting important vessels. Next, please. And then, by following the omohyoid to the suprascapular notch, locates the suprascapular nerve. And in order to finish the identification of the important elements, one should retract the fat pad and the lymph nodes medially away from the anterolateral border of the trapezius at the level just above the clavicular insertion. This helps in locating the spinal accessory nerve if one needs to do, and this is frequently done. If one follows these guidelines, one should finish the exposure without spending too much time. Then, next please, following the there is no role here, next please. There is no role for neurolysis of the neuroma, even if there is distal response to electric stimulation. If the indications were followed, meaning no recovery of active elbow flexion against gravity by the age of 3 months or incomplete injuries, then excision of the neuroma and putting grafts or neurotization is needed. There is absolutely no role for neurolysis of the neuroma, since all the papers about this condition, they all presented poor results after that. The neuroma is cut in the middle, and then gradual resection is done in both directions until healthy nerve fascicles are found. And when the healthy nerve fascicles are found, one can now make a map of what is available as roots with extraforaminal rupture that one can use to graft the distal plexus. And if one needs to use neurotization or not. Next, please. If at exploration of complete lesion, the C8 and T1 root appear intact on exploration, while there are no clinical signs of recovery, especially with no response to intraoperative nerve electric stimulation, this means intraforaminal avulsion. In this condition, neurotization of the lower trunk with some other source should be done. One should not say that this looks okay, it would recover. If it recovery would have already done, it has, or one would see clinical picture before going to surgery. Next, please. Now, reconstruction of the plexus should start with sural nerve grafts from the available healthy roots, ruptured extraforaminal. Restoration of shoulder abduction and external rotation, elbow flexion, elbow, wrist, and finger extension, wrist and finger flexion should be the aim. However, relative or complete absence of available healthy nerve roots might make reaching this aim difficult or sometimes impossible. So, next, please. Other sources of axons, if such condition is available, should be used. Next, please. The spinal accessory is frequently joined to the suprascapular nerve. In C5-6 injuries, neurotization from the ulnar, the median, or the radial nerves to the motor branches of the biceps, brachialis, and deltoid is sometimes done. In C5-6-7 injuries, neurotization of the elbow flexors can still be done from the median and ulnar nerve. In complete injuries, neurotizing the lower trunk is a priority. This can be done when there are 3 or even 2 good, healthy nerve roots with extraforaminal rupture. With only 1 healthy nerve root available, the use of contralateral C7 becomes necessary. Nerve grafts are passed subcutaneously across the neck to connect it to the lower trunk. The sural nerve will not be enough for grafting all these deficiencies. And so one can use the superficial radial nerve, the medial cutaneous nerve of the forearm in order to use this, or probably some other options as well. Next, please. What's the role of intercostal neurotization frequently used in the adults and in the adolescents, sometimes in traumatic brachial plexus injuries? Intercostal neurotization in babies should not be used, as the long-term effect of their use results in the formation of the growth of the affected ribs, with great reduction of the space available for the lung in the affected hemithorax. And this is a serious drawback that made most of the authors in this field decline to use the intercostal neurotization in such an age. With this, next please. Post-operatively, some form of immobilization of plaster splint are used to significantly reduce the head and neck movement of the baby, as well as those of the upper limb. This is kept for 3 weeks, following which physiotherapy is resumed. Thank you very much. Okay, to you, Ayman, now.
Thank you, Dr. Sharif, for such a nice presentation. And now, Dr. Yasser Safuri will be presenting on behalf of Dr. Alex because of his quarantine problem. He will give us a lecture about muscle transfer and its role in reconstruction Erbs Palsy. Dr. Yasser.
كده سامعني؟ Okay. Okay. Great. Okay. So first of all, I want to hope the best health for the. Okay, everyone hears me? First of all, I want to hope the best health for Dr. Alex, and we'll hope that he can come back to his work and share us in the coming webinars. I will present the lecture which was designed that Dr. Alex will present about muscle transfers for shoulder reconstruction in Erbs Palsy. There are certain inclusion criteria. When do we do muscle transfer? First, if a child is above 2 years old, having good elbow and hand function. By X-ray, there is no hypoplasia or severe deformity of the head of the humerus. He has good latissimus muscle and teres major muscles, and he has a good supple shoulder movement. That's why most of these patients are advised for physiotherapy before surgery with a program to reach very good passive range as much active range as possible. So, what results can you expect from muscle transfer? The patient and his relatives come to you and say, what will we reach after doing this type of muscle transfer? Or other doctors tell you, why don't you just do an corrective osteotomy? So the results of the muscle transfer depends on certain criteria or certain factors. It depends upon the strength of the deltoid muscle, as we mentioned before, the degree of contractures, which are examined preoperatively, the humeral head deformity or the glenoid hypoplasia, and also the elbow function. Because at the end, you do your surgery for the shoulder so that the patient can reach a great distance, can reach far objects. So if you reconstruct the shoulder, but the elbow is tight, then you did not achieve your aim. So this is one of the factors. A strong deltoid muscle will give you a good result. But here, there is a weak deltoid muscle. The patient is unable to abduct the shoulder more than 90 degrees. So if even you do him a muscle transfer, it won't give the good result as the patient before. You should explain this to the patient and the relatives. Also, if the patient has a head deformity and coming with this type of head destruction, what will be the results? As I said, don't forget the elbow. Preoperatively, even if you are not doing him surgery for the shoulder, is advised for splints and correction of the elbow contractures. Post-operative, after you do a muscle transfer, the protocol of physiotherapy should include also the elbow. Sometimes, when you do the surgery and attain a good function for the shoulder, maybe you will advise the patient to do surgery for the elbow and correct the contractures. You should reach your goal and achieve a good function results. The patient wants to raise his hand and reach far objects. There are different soft tissue procedures which are mentioned in the literature, beginning from just release of the subscapularis and the capsule through the anterior approach, Fairbank in 1913, or release of subscapularis and the pectoralis major by Seaver in 1918. But later on came the era of the muscle transfer, which are functional. We take the latissimus tursi or the teres major muscles through different approaches. So there was liposcopic transfer, and then the Hoover technique using a posterior approach to transfer the muscle directly on the rotator cuff. This is the technique which we use, most of us, is the Hoover technique. This type of muscle transfer is through a posterior approach, where you take the latissimus tursi plus minus the teres major, and we're going to talk when to use this or when to use both. You transfer them directly on the head of the humerus on the insertion of the rotator cuff. But sometimes you cannot external rotate and abduct the shoulder put your muscles in place. This is when you do a subscapularis release. This technique, you release the subscapularis proximally from the bone. You strip it from the bone. This is called recession of the subscapularis. The aim is that the muscles which are transferred will do the role of the rotator cuff. What is the role of the rotator cuff? They stabilize the head so that the deltoid can perform its function of abduction. So our aim is to reconstruct the forces created by the rotator cuff. This is through transferring these muscles, latissimus or the teres major, to the insertion of the rotator cuff. Balance score is the score most of us use the Mallet score. This Mallet score gives a global idea about the function. So we say overhead elevation, hand to mouth, hand to head, hand to back. But all of us agree it's simple and gives us a quick idea about the function pre-operatively or post-operatively. The approach is a posterior approach where we use one muscle or two muscles. This depends upon several things. First of all, if there is pre-operative contraction, co-contraction. So if you ask the patient pre-operatively to overhead elevate and you have spasm and contraction of the muscle in the posterior axillary fold, so there is co-contraction of the teres major. This condition should be transferred with the latissimus. Otherwise, it will be an obstacle. Release of the subscapularis is a must if you cannot achieve the position which you want, which is maximum external rotation and abduction. Then you strip the subscapularis from the bone as one unit, together with this blood supply, nerve supply, until you achieve passively the correct position of abduction and external rotation. At this point, there is relocation of the head. The head preoperatively is subluxated posteriorly because of the internal rotation. You can never do a muscle transfer on a head which is subluxated posteriorly. You should insist and you should feel that you have relocated the head in place. It is relocated when it is abducted and external rotated. When you abduct and external rotate the shoulder after releasing subscapularis and you are sure that the head is in place, this is time of putting the transfer muscles directly on the head to stabilize it. Skin incision is a hidden incision because it passes behind the deltoid and goes through the axillary space or fold. This is a hidden scar. You dissect properly until you reach the two muscles, the latissimus and the teres major. Another decision is made when you enter and do your operation about which muscle to use. Sometimes your plan is to use the latissimus dorsi only. But when you do your approach, you can find the latissimus dorsi atrophic. It's not so healthy. So at this time, you should use also the teres major. Some surgeons like to use both of them as a conjoint tendon. They stick them to each other and they transfer them directly as one unit. But other surgeons like to separate them and like to insert them separately, directly on the head. So as you see in the slide here, there are two muscles separated from each other, pulling them on ease. They have their excursion and ready to be transferred. The other slide here, as you see, you go under the deltoid muscle. We don't like to split the deltoid muscle and pass the tendon through it. we abduct, external rotate, and we pass underneath the subscapularis. Whenever you want to do a subscapularis release, it's done at this moment of surgery, when you have dissected the two muscles and very comfortable with the approach, but there is no enough external rotation abduction. Then you can go at the level of the border of the subscapularis, which is very easy here after dissecting the muscles, and you strip the muscles from the bone until the muscles are completely free from the bone, all the way around the scapula until inferior part. And you can feel that the scapula will take a new position. Then you go back and you do your fixation of the tendons directly on the head. As you see in this slide, there are two tendons. Each of them is pulled with this excursion and fixed to the bone through an osteoporosteal flap under the deltoid. A nice trick here, because the area is very deep, you can use a knot, sliding knot. The giant sliding knot, which is used by Dr. Pfleger, is a very suitable knot in deep areas where it goes and slides and locks in place. This will make surgery easier. This approach also allows you to extend the approach if you need to do a type of bony surgery, like in cases of curved big acromion. You excise this acromion. So as you see in the slide here, this big hole over here was the acromion, and this structure beneath is the head. It was an obstacle for the reduction, an obstacle to reach satisfactory abduction and external rotation. You can never do your transfer if the head is not reduced. A nice trick which you can do preoperative for planning is to do an X-ray in different positions. Then you can see the impingement or the bone hitting the acromion, preventing it from abduction. Then you can predict that if there is a problem in the reduction, then you can extend your incision and do an open acromioplasty. Okay, this is a patient coming to you as good deltoid. Then you can do a muscle transfer and you expect good results. Very good overhead elevation. It's according to the Mallet score, it's a global overhead elevation, which is satisfactory for the patient. Here, the slight flexion of the elbow will improve with time and with physiotherapy program. That's why a physiotherapy should know and understand that the long-standing Erbs and internal rotation of the shoulder definitely will cause a contraction of the elbow. So if we correct the shoulder and with gravity, the elbow will correct with time and with some protocol of physiotherapy, which is advised. She will have good external rotation and good overhead elevation. This is also a patient which has very strong deltoid. You can expect a good result. This is the good result of the patient, and very good overhead elevation and improvement in function. The same for this patient. And this patient give a nice idea about the results of muscle transfer against derotation osteotomy. Because if this patient, you did him in the past, they used to do a derotation osteotomy, and he has a very good deltoid and very strong internal rotators, then there is a recurrence. This patient only wants balance, muscle balance. But what about this patient? She has weak deltoid, weak abduction less than 90 degrees. You cannot expect an excellent result from this patient. This is her maximum result, which we can achieve, better overhead elevation, but the problem here is not from the type of surgery, but from the beginning, the weak muscles. This is another patient, as you see, has weak deltoid, so you'll expect less results than those with very strong deltoid and preoperative good abduction. If a patient comes to you, an older patient with this, as you see here, has severe internal rotation, but have very strong deltoid muscle. What can you do for this patient? Is it enough to do corrective osteotomy, or is it advised to do him corrective osteotomy and then later on functional muscle transfer? Most of these patients, if it's possible, to do a derotation osteotomy and then a muscle transfer, prevent recurrence and then return again in internal rotation. There should be muscle balance. But not on all patients you have a head deformity. Sometimes it's very minimal. So we can consider these patients for muscle transfer and they can give very good results. So this patient had slight head deformity, but muscle transfer was done for her and a proper physiotherapy program, and she ended up by a good result. As we mentioned before, there are certain situations where there is no good shoulder function, even by other procedures which were done to improve the shoulder function, like in case of microsurgery, when the patient was operated upon for microsurgery, he improved, but still there is no overhead elevation. You should not stop. You should think, what can you do for this patient to achieve your goal of overhead elevation? For a patient which already had a decorrective osteotomy or derotation osteotomy in another hospital, and then he came to you, but still he does not have overhead elevation. He has improvement of the appearance of internal rotation, but has no function. This is the patient with microsurgery. Still, we as microsurgeons are not happy about the shoulder. We will not stop. We'll think of doing her muscle transfer if it's possible, and if she has a strong latissimus dorsi. So as you see in the slide, this is the incision of the microsurgery, and then this is the incision of the muscle transfer. And she achieved very good results. But if you don't have a latissimus dorsi, if you don't have a strong latissimus dorsi, is there other options? Yes, some surgeons recommend using the trapezius. The lower part of the trapezius can be used in certain conditions, like in recurrence of deformity of a muscle transfers, or in cases in which there is weak latissimus from the start, then you can use the lower part of the trapezius for reconstruction. Never give up. You want the patient to reach far objects. You want the patient to have a good shoulder function, which is important for all the activities. As you see here, this patient underwent a derotation osteotomy. The parents are not happy because she cannot reach far objects. It's only for cosmesis. What you can do for this, you can do her a muscle transfer to augment the function. And the patient is happy relative to the first results, because now she can achieve an overhead elevation which is suitable for most of the activity. Post-operatively, the patient is placed in a shoulder spica for 6 weeks. Then a night spent in the same position for another 3 weeks. But internal rotation is contraindicated in the physiotherapy program until 3 months, after which you begin gradually internal rotation with overhead elevation. Exercises are a must, continuous exercises in his life. And you can advise him to do sports, any overhead sports like swimming or volleyball, so it becomes his hobby, because this prevents recurrence. As you see, this patient had a good family caring for him. They were also always doing him exercises. So he achieved a very good result. and he even was a in the swimming team. Swimming gives you very strong muscles, and the patient can continue without physiotherapy if he's a swimmer. This is my advice for post-operative most of the muscle transfers. Thank you very much.
Thank you, Dr. Yasser, for this nice presentation. And now we'll step into the arthroscopy part of the today's event with Dr. Bassem Flega. He will discuss with us the role of arthroscopy in managing of Erbs palsy deformity and contraction. Dr. Bassem.
Thank you very much for
باسم احنا سامعين وشايفين حضرتك اتفضل.
بس
شايفين برزنتيشن اتفضل.
Okay. I cannot see the presentation, but I will talk. Well, arthroscopy actually is now involved in the treatment of Erbs palsy, mainly in old children, young adults, and even adults, as I'm going to show you. Yes. Well, the etiology and pathology is well described by my colleagues, so I will skip that. Just I want to mention that most infants with brachial plexus palsy will recover with daily physical therapy exercises. Now, the problem is that external rotation weakness secondary to obstetrical brachial plexus palsy lead to internal rotation contracture of the shoulder, causing functional and cosmetic problems. The persistent muscle imbalance and soft tissue contracture can lead to progressive glenohumeral deformities. Now, the treatment, as mentioned before, is non-surgical treatment, daily physical therapy, and the surgical treatment when there is no change over the first 3 to 6 months, as nerve graft, nerve transfer, or release and tendon transfer. The target of the physical therapy is to break the advancement of the disease by keeping normal passive motion to avoid contracture, stretching and strengthening of elevation and external rotation, and continue that for at least 6 months to 1 year. The arthroscopic options of treatment are arthroscopic anterior capsular and subscapularis release, arthroscopic subscapularis release with open latissimus dorsi transfer, or the 2+3 repair technique for limited goals, which is a technique we use, which I'm going to explain later, mainly for adults. Now, the arthroscopy is done in a sitting position with a standard posterior portal for visualization and an anterior lateral portal for instrumentation. The types of anterior capsule and subscapularis release are a longitudinal cut or an oblique cut, or a sieve capsule release, which are we using now. The results in the literature according to age groups, we group them to patients below 3 years, patient between 3 and 8 years, and patient between 8 and 16 years and above 16. Now, also in the literature, the gained external rotation after arthroscopic release will remain in the young children and older children. For example, this patient, 5 months after surgery, before surgery, he had no external rotation. A release was done, and the arm is placed in an external rotation spica. And after 5 months, he has more than 60 degrees external rotation and a good elevation. This patient had a failed open derotation surgery. We did for her an arthroscopic release, and this has improved her external rotation. The patient's age between 8 and 16 years, the gained rotation remains, and most of them needed transfer beside arthroscopic release of contracture. This 13 years old patient, 4 months after surgery, has a good elevation and a good external rotation.
Okay.
This 17 years old patient, he has a good elevation, but his problem is in external rotation. He has a head deformity, and this is bothering his daily living activity. So he wanted to improve this external rotation. Now, we did a surgery with zip release of the anterior capsule and put him in external rotation spica, and he gained about 45 degrees of external rotation. This case is a patient 20 years old with limited elevation and external rotation with a posterior subluxation. An arthroscopic release of the anterior capsule and subscapularis was done, beside reposition of the head anteriorly and open posterior capsular shift and latissimus dorsi transfer. This is the patient the day of surgery. Elevation is about 100 and no external rotation, it is minus. And after surgery, he got this external rotation spica. 8 weeks before post-operative, the patient has a good external rotation. His elevation improved slightly, and he was very happy. Unfortunately, after 1 year, the patient lost of about half what he gained in external rotation, and maybe the reason he didn't do the exercises properly. Now, adult patients. For adult patients, we use a technique which we call 2+3 arthroscopic intervention with limited goals. These are patients who do not use the affected arm completely. They use only one arm. So we do this intervention to enable them to eat, to write, and shake hands, which is a very important function, especially if the affected side is the right side. Now, this 2+3 technique with limited goals is a bone intervention, a two-bone intervention, a subacromial decompression and resection of the protrusion in the greater tuberosity, and 3 soft tissue interventions, the cruciate reconstruction of the supraspinatus, which I'm going to explain, and the oblique cut through the subscapularis and also release of the inferior capsule. This is done to get the head, which is superiorly subluxated, in its position down. The instruments used is the giant needle to pass a transosseous suture through the head, and the so-called chop needle puller to pull the suture through the soft tissue. Now, it is based on making a T-shaped incision on the hyperredundant supraspinatus tendon and capsule, and then overlapping these 2 flaps on each other to shorten the width of the supraspinatus and tight it laterally. The technique is done by a T incision, and as I said, And then we pass a suture through the bone with a giant needle. And then with a chop needle, we go through the tendon to pull the suture inside the tendon, inside the posterior flap. And then we tie the posterior flap by pulling it anteriorly and fix it with another 2 or 3 sutures. Then put another suture posteriorly and also pulling it with the chop needle through the anterior flap and tie it over the posterior flap. So we have cruciate reefing and at the same time increase the width of the supraspinatus. This is an intraoscopic view of this operation. Here is above on the left is the supraspinatus is ballooning above the biceps and the head. And below we see after reefing, the supraspinatus is tied immediately over the biceps tendon. Now, adults after surgery, they have to do physical therapy for 30 minutes at least a day, and this for 1 year, in order to keep the gained limited goals. This is a patient, 27 years old, and he had an active elevation of 40 to 80, an external rotation of -20. He had a relatively passive elevation of 80 and passive external rotation of 0 to 10. He never used the right arm. He always was dependent on his left arm. So his aim was to use his right arm in order to shake hand with other people and to write with the hand and also to be able to eat. So these are the limited goals. This is the same patient 3 years after surgery with successful limited goals. He is still doing every day 10 minutes exercises for stretching of the external rotation and elevation at home, of course, and using a rubber band to strengthen elevation and external rotation. In conclusion, besides the advantage of arthroscopic interventions being less invasive technique, we have good results in arthroscopic release of anterior contraction. We also may consider tendon transfer associated with the arthroscopic capsular release. And we have a successful limited goals intervention in adults. It's very important, very essential to have a post-operative daily rehabilitation for at least 6 to 12 months after surgery, and maybe every day later for at least 10 minutes. Thank you very much for your attention.
Thank you, Dr. Bassem, for such a nice presentation. And now it's time for Dr. Simon Lambert. He will give us a lecture about correction of bone deformity in Erbs Palsy. Dr. Simon.
Hello, thank you very much indeed for having me on this wonderful seminar. Can you hear me?
Yes, Dr. Simon, we hear you well.
Lovely. And can you see my screen, please?
Not yet.
Okay, let's have a look.
Yes, you can. Yes, we can see you now.
Good. And then I'll give you my screen.
Yes, it's now. You can see it now.
Good. So thank you very much indeed for the invitation to participate. What an interesting but difficult subject. I'm going to talk a bit about the bone deformities of Erbs palsy, and just to start off by rehearsing or reviewing the embryology of the upper extremity a little bit, because that's rather important and interesting in the evolution of bony deformities. We can see that the scapula body in young people with Erbs palsy remains normal in its shape, size, and form in the usual case. We also know that there are deformities of the acromiospinal arch and, of course, of the acromioclavicular joint. That part of the scapula, together with trapezius, is derived from a branchial arch, and in conjunction with the third part of the scapula, the glenocoracoid block forming the glenohumeral joint, are the two parts of the scapula which become most deformed. And I think that is rather interesting. I'll come back to that in a little while, but that will help us to distinguish cases of other causes of scapular deformity in childhood from those of the Erbs palsy. Here's an example of a three-dimensional plastic model taken from a CT scan of a 14-year-old girl with a group 3 palsy who has great functional and cosmetic deformity and disability. And you can see the great deformity of the acromiospinal element, the branchial arch derivative. It's hypoplastic. It's very dysplastic. The scapular body remains pretty well normal in its shape and form, whilst there is no recognizable glenoid, apart from a small stub of bone posteriorly, which my colleague and mentor, Professor Birch, had implanted to try and stop the humeral head dislocating more posteriorly in this girl's infancy. So that bone block at the back of the glenoid is iatrogenic. It's not part of the natural glenoid. In other words, this glenoid and coracoid, which is virtually absent, was never formed at all. And that's very interesting because we all are taught that the deformities of Erbs palsy are due to and consequent upon the nerve palsy, the asymmetry of muscular activity. But this young woman's case illustrates another possibility that actually the potential for those embryological elements to form is largely due to a nutritional, a vascular supply during intrauterine growth. And of course, what happens after birth to the parts of the shoulder blade which are potentially able to grow is determined by the asymmetry of muscular pull. But I would be very interested in my colleagues' views about the possibility that some babies are predisposed to worse scapular deformities even before birth. If that's true, then there's a very important group of babies which we need to think about in a different way. And one reason I say that is the glenoid deformities that we see are very similar to other epimetaphyseal dysplasias, which are due to genetic vascular deficiencies. It's a fascinating subject, which I haven't got the answer for, but I put it to you that there is something in there. What we're going to consider now, though, are 4 things. The bony requisites for scapular suspension and scapular orientation, the scapular processes, acromiospinal and coracoid, the scapulohumeral joint, and humeral length and torsion. Each of these 4 parts of the equation contribute to shoulder deformity. Thinking about scapular suspension, this is all about the clavicle. Now, the clavicle is often short in obstetric brachial plexus palsy, not just because it has been broken. In fact, clavicular fracture in obstetric palsy is relatively rare. And here are cases of young adult Erbs palsy where the clavicle forms a bony tether so that the scapula is dragged forwards into protraction around the chest wall, increasing the loss of external rotation, active external rotation. If we examine such patients, they often have external rotation relative to the scapular plane, but the scapular plane is protracted anteriorly or ventrally. And in these patients, I've used the techniques of monorail distraction osteogenesis, and you see how it's applied. And in this young man, at the full maximal range of extension. Now, sometimes one has a regenerate which forms beautifully, as in the case on the bottom left, and sometimes one has a regenerate which is extremely fragile, in which case internal fixation before the regenerate consolidates becomes necessary. But this technique we've written up in the Journal of Pediatric Orthopedics as a way of reorienting the scapula for optimal glenohumeral joint movement. Now, the next bit of the equation, of course, is the acromioclavicular joint. And you see here in the 3D reconstructions of a CT scan how in this particular patient with Erbs palsy, the scapula is pretty normal. The acromiospinal process is normal. The glenoid is slightly hypoplastic and the coracoid base very broad. So this is a glenocoracoid dysplasia, that third part of the scapula under the homeobox gene mechanism. But this clavicle is now rotated at its outer end by at least 45, if not 60 degrees. And it's unclear to me why that should happen. It seems unlikely that this is a contracture of the anterior part of trapezius when the rest of the trapezius appears to be normal. This is interesting because at the medial end, the sternoclavicular joints are usually normal. So this seems to be a true rotational dysplasia of the clavicle, leading to the acromioclavicular joint being at its maximal range of torsion already. So there is no possibility of elevation of the scapula at the end of the clavicle. Now, again, I don't know why this happens, but my treatment for that is a clavicular derotation osteotomy, of course. That makes sense. And that's sometimes in conjunction with clavicular lengthening. Notably, the coracoclavicular ligaments in these patients appear to be intact and well formed. If we go further to the outer end of the acromion, and in this case, you've got a relatively well-formed acromioclavicular joint. So in this case, a male patient aged 19, the deformity of the distal end of the acromiospinal process must be clearly postnatal and caused by deltoid contracture or a tether in the contracture, as was mentioned earlier. So here's a clavicle that is relatively normal with an acromion that is beginning to tilt ventrally and a coracoid that is also tilted ventrally and short. You can see the immense ridge of bone down the anterolateral aspect of the humerus, which I think is the insertion of this very dysplastic or contracted deltoid, which is behaving like an anterior tether. So in these cases, in order to correct the subacromial space and to allow the humerus to be brought forward again onto the acromion, onto the glenoid, I beg your pardon, because the humerus is being forced backwards by proximal humeral normal rate of growth velocity within the crowded space of the acromiocoracoid fornix, it's simply pushed out posteriorly, but the humeral head is relatively well formed. So here, in order to get the relatively well-formed humerus back onto the glenoid, we have to think about acromiospinal osteotomy and coracoid surgery, if necessary, to allow the humerus to go back in. But that can't happen if the deltoid is tethered. Deltoid release is difficult when the deltoid muscle is abnormal. So what I have done in these cases is to shorten the humerus above the deltoid insertion, to allow the deltoid to be relaxed a little in order to then do the acromiospinal osteotomy. But the problem with that, of course, in a male age 19 is that there's no more growth left in the distal humerus to equilibrate arm length. And many people are very disturbed by dissimilar arm lengths. So one then has to consider distal segmental humeral distraction osteogenesis. The all-important glenoid and the glenoid-humeral relationship is even better illustrated in this case by the feature of the deltoid contracture, but there's also the possibility of conjoined tendon contracture. The coracobrachialis is the antagonist of the deltoid. It too is affected in the upper trunk palsy through the musculocutaneous effect. So both muscles can be contracted and cause this immense crab-like or claw-like closure of the fornix of the glenoid. Now, in this case, the humeral head is abnormal and the glenoid very dysplastic. And trying to restore that relationship would require a version of a triple osteotomy, acromiospinal, glenoid, and coracoid, possibly also humeral. These patients are often, interestingly, because they've never been in a joint articulation, they're often quite comfortable, but limited in function. And it's these patients in whom a derotation humeral osteotomy for functional positioning of the hand in space might actually be the most appropriate treatment rather than an attempt to restore the anatomy of the lateral scapula. However, if you do a humeral torsional osteotomy to recenter the humeral head in infancy, with growth, changes happen in the humeral head orientation that can be very problematic. This girl had an operation in her infancy, age 10, and again age 13, to bring the humeral head from a posterior subluxation into the glenoid. So she had anti-torsion osteotomies twice. Then she grew between the ages of 13 and 17, and as a result developed anterior subluxation of the humeral head when her elbow was in the anatomic position. So she complained in my clinic of anterior instability. Well, the obvious thing to do with this young lady was to take the plate away and to perform a derotation osteotomy at the site of maximal deformity of the humerus, and we have restored her glenohumeral biomechanics in doing so. So we have to be aware that growth influences what happens to our osteotomies, particularly under the influence of asymmetric muscle pull as the child gets older. And if we get it wrong and we try to contain a humeral head where there's anterior tethering, posterior weakness, and we try to block the movement of the humeral head backwards by a bone block, we can generate arthritis. So the principle of containment by an obstructing bone block as opposed to a supportive bone block with glenoid osteotomy can lead to very devastating results, which then need other forms of treatment, such as joint replacement. So in that brief summary, I've suggested that we've got 4 things to consider: scapular suspension through clavicular surgery, lengthening and derotation osteotomies, and acromiospinal osteotomy to realign the acromioclavicular orientation. That may require release of the deltoid and consideration of the humeral length. We have scapular processes, which are including the acromion and coracoid, where we can undertake shortening osteotomies or realignment osteotomies, but these depend on the soft tissues for their ability to correct deformity. We've then got a range of options for treating the displacing and displaced humeral head, including glenoplasty, that is reorientation of the glenoid fossa, or glenocoricoplasty, that's reorientation of the entire lateral angle of the scapula, including the coracoid base. Scapular neck osteotomy, which is even more challenging, where you're reorientating not just the alignment, but also the rotation of the lateral scapula. And then various bone block procedures, which, as I've explained, are things that I have learned to not rely upon. That can be done in the later child with additional proximal humeral rotation osteotomy, but we have to beware of the effect of growth. So bone deformities must be seen in the context of asymmetric weakness and the contractures or tethers. We do like to try and restore the bone as a framework to restore muscle length tension relationships, to optimize the actions and the activity of the muscles that are able to work. But we have also, and it's been emphasized by my friends and colleagues already, that have to appreciate that growth influences the eventual shape and orientation of the shoulder. And we have to be very careful what we do and when. And I'd suggest to you that we have three broad concepts: containment of the humeral head in the infant, facilitation of muscle activity in the growing preschool child, and scapular orientation in the older child, together with muscle transfers for elevation. And with that, I thank you very much indeed for this privilege of joining you this evening and for your attention. Thank you very much.
Thank you, Dr. Simon, for such a valuable lecture. It was at the level of illustration as we already expected to be. Hope to see you again in Cairo soon, either in the AO event or sure the coming event in our association.
Thank you very much.
Thank you, Dr. Simon. Unfortunately, I know you had to go to the OR to continue your cases.
Thank you.
Hope that everything will go well. We'll see you again soon, and thank you very much for your presence. Thank you, Dr. Simon.
It's been my pleasure. Thank you very much.
See you soon. Bye. Dr. Yasser and Dr. Bassem, would you please, we'll now need to start a part of a discussion of the webinar. Dr. Sharif.
Yes.
We had a lot of questions from the audience, but we start with Dr. Bassem. There was an inquiry about the use of arthroscopy in younger age. Do arthroscopy had a role in children about 3 and 4 years with Erbs Palsy in sort of a release, doing a release?
Hello, you hear me?
Yes, Dr. Bassem, I hear you. Do you hear me?
Yes, yes.
Yes, there was a query about the use of arthroscopy in younger children.
Yeah. Well, we if the patient has anterior contraction of the capsule and the subscapularis, we can do arthroscopy starting from 5 years or so on. For me, there's no problem. I think also I did one below less than 5 years old. It is a quick and very effective surgery. It takes about 10 minutes, 15 minutes, and that's it. Beside other treatment needed, it will be very helpful, yes. So we start with young children also, but I think not less than 4 or 5 years.
Do the release is similar to that on the adults? I mean, do we have to open the interval and do a capsulotomy, 360 capsulotomy?
Yes, of course, yes. We open the interval and do first capsulotomy and try the external rotation. If we get a good external rotation, after capsulotomy, then we'll stop and then the patient is put in the cast. Or if it is not enough, so we also release the subscapularis. I usually do this oblique incision in order to have lengthening of the subscapularis. And by putting the shoulder in a spica for 6 weeks, subscapularis will heal with elongation beside the capsulotomy.
Dr. Yasser.
Yes.
Yes. About the tendon transfer and Erbs palsy, do you always do imaging of the shoulder to be sure that you have a joint that is congruent more before doing the surgery, or it is age related? If you have a young children 3 or 4 years, it's not necessary.
Yes, if you suspect that there is bony changes, like in old ages, above 4 years, then an X-ray is important, a regular X-ray. But if you find that X-ray proves that there is a large acromion, then you can put the shoulder in different positions and take the X-ray to give you an idea if you are going to remove parts of the bones or not. It's age related, yes.
Yes. Dr. Mustafa Sherbini from the audience is asking about the CT. Is CT mandatory in all cases?
Sometimes if you don't know how to plan the surgery and you don't know, sometimes there is overlap in the X-ray, as if the head is completely out of the glenoid. In these cases, you do a CT scan, because you can never do a tendon transfer and the head is out of the glenoid. So it's a big problem if you have the head completely subluxated posteriorly and you have the glenoid and you have changes in the acromion and the coracoid. And these, we think at all, any reconstructive surgery will help, only cosmetic for derotation or softness.
Yes, sir, there was an inquiry about the trapezius transfer for shoulder abduction. Would transferring the trapezius affect the scapular motion in a child with a good scapular motion? If you take the trapezius and attach it to the humerus, will this be weakening of the scapulothoracic motion?
Now we take the inferior part of the trapezius. It's a very good tool in revision surgery. Sometimes you find the patients coming doing transfers with different incision, and you do not know if the surgery was done right or wrong, and you don't know if you're going to find these tendons of latissimus to do a revision. In these conditions, it's very safe that you use the inferior part of the trapezius and you lengthen it a little bit, and you use it mainly for the external rotation, and it does not change anything of the biomechanics of the shoulder. And in the literature, I did not try it. Sometimes they use the contralateral part of the inferior part of the trapezius as a source of motorization of the other shoulder. So the inferior part of the trapezius is a safe procedure, and it's used in revisions or in cases in which you don't have any strong muscles to use for motorization of the shoulder.
Dr. Basim, we had another question from the audience about patient with mild or moderate dysplasia of the shoulder at the age of 6 years or more.
I didn't hear the question.
What about a patient with moderate dysplasia of the shoulder? The head of the humerus is already beginning to change.
Yeah.
If you have do you have to do an anterior capsulotomy and a full release before tendon transfer if you are doing a scope?
I will do an arthroscopic capsulotomy. Is that the question?
Yes. You're asking a
phone.
Yes.
And the patient has no external rotation and no elevation. So usually the capsular release in these old children will bring more external rotation, but its effect on elevation will be limited. That's from my experience. But you know that the main function of the shoulder is external rotation. You need external rotation while you are eating, while you are writing, and this is a very important range of motion. So by getting the external rotation better, the patient can increase his function very much in daily living.
Okay, thank you, sir. Dr. Sharif.
I think I answered your question.
Yes.
I want just to make a comment just very quickly because of the question asked to Dr. Yasser. Well, I was very actually impressed by the presentation of Dr. Simon. So I think maybe it is wise that now before planning a surgical intervention in Erbs palsy, we do a PSI, a model like he showed for the scapula and the humerus and the clavicle, and to see the relations. And I think this will be very helpful in planning. So I think I will start using that in these cases. Thank you.
Okay. Dr. Sharif.
Yes.
There are also a question about the role of the AMG and nerve conduction study in the early 3 months of Erbs palsy, and if there is an essential role for the myelogram.
Let's first, myelogram is an invasive procedure, and it necessitates to have it doing a CT scan, which needs anesthesia in less than perfect conditions in the radiology department. Now, this has fallen out of disfavor in the whole world. So I don't think there is room to use it anymore. Particularly, the decision to operate or not is mainly a clinical one. It does not depend on nerve conduction. It does not depend on whether myelogram results or not, because there were large false positive and false negative findings as far as myelomeningocele were concerned. So in practice, the nerve conduction is not essential in order to take the decision to operate. And the myelogram is not important because exploration would show clearly whether the root was avulsed or there is an extraforaminal rupture.
Okay, thank you, Dr. Sharif. Dr. Yasser. Dr. Yasser.
Yes, yes, do you hear me?
We have a couple of questions about the this transfer will affect the internal rotation of the patient, the active internal rotation, and is there a difference between transferring them as one block and transferring them as different muscles? Yeah, separate the muscles before transfer or transfer them as one block.
Okay, these two muscles, latissimus and teres major, if you use them as one block, then you have lost two forces. You have created only one force. So better than if you can separate them, then you are going to use them separately, and you adjust the tension on both of them. You find that the tension is not the same on both of them. The latissimus needs more pulling. The teres major needs less pulling. So it's better to separate them to adjust the tension. And also to cover all the head when you relocate it and create like a footprint. So better to use both of them separately. Are you going to lose any forces here for internal rotation? Better if you have a strong muscle, strong latissimus tursal muscle, and you do not have any co-contraction of the teres major, use only one muscle, which is the latissimus. But if you have co-contractions, you use both muscles. But even if you use both muscles and you do a release posteriorly or proximal release of the subscapularis, you still have the pectoralis and the subscapularis anterior for internal rotation. So there is a balance. You do not lose internal rotation. At the same time, you create a balance between external rotation and internal rotation. So the answer to the question, if you use two muscles or one muscle, it does not affect much the internal rotation, especially if you do your release from the bone without interrupting the muscle unit of the subscapularis.
There is a question from one of the audience about is there a role of arthroscopy in a posterior subluxated shoulder? Can arthroscopy help in restoration and stabilization of a posteriorly subluxated shoulder?
The posteriorly subluxated shoulder is due to weakness of the posterior capsule and ligaments, so that the head subluxate posteriorly if there is no any other muscular problem. So arthroscopically, it is possible to make an inferior capsular shift posteriorly. It is a cruciate repair of the posterior capsule in order to make it smaller and tight it, and at the same time use this to through the cruciate repair you can increase the thickness by overlapping to twice as it is, and then of course after that the patient has to also stay in a cast in external rotation for 6 weeks till the capsule heals in its a new position. So the answer is yes, it is possible, and the results actually are very good. Thank you.
Thank you, Dr. Wes. Sharif.
Yes.
There is a question from Dr. Muhammad Odba about neurolysis of the neuroma before excision. Just do a neurolysis in a partially affected brachial plexus.
Okay. Well, if one has a upper brachial plexus injury, upper type, this means no elbow flexion, no recovery of elbow flexion against resistance by the age of 3 months. When we do not have any resistance, any elbow flexion against resistance, not even visible contraction of the muscle, then we have an indication for exploration. The results of the surgical published series of authors who used neurolysis in such cases were all gave disappointing results as far as recovery of function is concerned. And so all the conclusions of such publication were one should not make only neurolysis, even if there is some response to electric stimulation. Whenever the clinical indication was present with inability to have elbow flexion against gravity by the age of 3 months, then excision of the neuroma and grafting or neurotization should be done, not neurolysis.
Thank you, Dr. Sharif. I'm afraid that the time is running from us and we have to proceed to cases. We'll start with the first case. We have a baby of 9-month-old. He had recovered the hand and wrist and good elbow motion, but had no shoulder motion. On exploration, and it was found that he had a C5-6 rupture. Our question: what to do? Either to do a neurotization or a graft. Dr. Sharif, what do you prefer in such condition?
Whenever you have on exploration good extraforamen, good roots, then you would have a good number of axons. Grafting in this condition is my preference, particularly in the young child by the age of 3 to 4 months. Not because neurotization does not give probably all the amplitude of the axonal number that is given by a good route.
Yes. Dr. Yasser, I think this one of your cases.
Yes.
Dr.
Yes.
Yes.
You want me to present it?
Yes, sure, please, you can go on.
Okay, so this was a baby, a child, 4 years old, and he has no overhead elevation. So I want to ask, is it necessary in this patient to do an X-ray? What are the tests which are done so that you can know if he has contractures or not? And also, is there a score other than the Mallet score which you use to evaluate the preoperative function?
Yes,
So
we would like to hear it from you. What is your experience with such a case, please?
Okay, in this patient, first of all, I'm going to try to reduce the position of the head in abduction and external rotation in both positions. In an abducted shoulder 90 degrees, I'll try to examine the full external rotation, and also in adduction and external rotation, and to feel if there's any contractions or not. If I feel there are contractions and the patient has good overhead elevation, deltoid, then I'm going to examine the posterior fold of the axilla for any co-contractions. If there is no co-contractions, if there is a supple shoulder and strong deltoid, then I go for technique, a posterior approach, taking directly the latissimus dorsi, relocating the head in place, inserting the latissimus through an osteo-per-osteo flap directly on the head, really relocate it, trying to support the footprint, putting the latissimus as broad as possible on its insertion, at least with 2 separate sutures. These sutures are like the anchors, which I use as sliding knot, the joint sliding knot. So I elevate the subperosteum, put the tendon as broad as possible, and fix it at its edges directly on the head. And then put the patient in a spica for 6 weeks, then a night spin with early rehabilitation. This with all these criteria, which are very suitable for muscle transfers, which is a good deltoid, good supple joint, no contractures, and he will have the best results according to the Mallet score.
Dr. Yasser, there was always a debate about the position of insertion of the tendon on the humeral head. Do you select a tendon by itself, like the infraspinatus or the supraspinatus, or just you place it on the head as externally as possible?
When you relocate the head, you put your thumb and push the head in place.
Yes.
You can figure out with your thumb where is the area where you're going to put your tendons on. If it's only one tendon, then you use the latissimus and you go with an osteotome to create an osteo-per-osteo flap, and you pass the tendon under it. Then you open the tendon as wide as possible in this place. If you're going to use 2 tendons and you want to figure out where to put them, the teres major has a shorter excursion, and I think it's better to put it when the shoulder is external rotated, but it is a little bit adducted. Then you put it, and it will be more to the lateral part of the head. When you use the latissimus, then you elevate the shoulder more. You will have space for the latissimus. It will be more medially. So at the end, you will find that the both tendons are lying beside each other. I think this is the ideal situation which will give you the best result. I don't like passing through the deltoid a split digital. Some surgeons do this and use both tendons as a conjoint tendon, just putting it on the head. I think that the technique of pulling each tendon alone and considering its excursion and tension and trying to imitate the footprint will give the best results. I just want to know also I want to know the opinion of Dr. Sharif Amir because of his experience in these cases. Does he use both tendons or one tendon? Is there any type of examination he likes to do for contractures? Dr. Sharif?
Yes, as you have mentioned, the latissimus dorsi and the teres major, they have different excursion. So it would not be very logic to put them both in one insertion point. Using the latissimus dorsi is usually satisfactory unless its power is not very good. And if such conditions, the result would not be good anyway. So, but anyway, I usually don't use latissimus dorsi and teres major in one insertion site. I agree with Dr. Yes.
Dr. Sharif, here we had a difficult case, a little bit of a difficult case, because we have a child that have recovered from a complete palsy at birth, with now presenting at 15-month-old with an elbow and hand that's recovered, but he has no shoulder. He's a little bit old for the formal surgical exploration and nerve repair or neurotization, and he's a little bit young for tendon transfer. Yes. What will be your decision? What will be your plan, sir?
Well, they were some temptation by some surgeon to see the results of what would be the nerve transfer procedure in such condition. In the obstetric palsy, sometimes there are axons that have crossed the neuroma that made the muscles not electrically dead by this time, 15 months, which is, if it were a traumatic injury in a normal situation, it would be too late to do any microsurgery. So sometimes having a good EMG, if there is good fibrillation, then probably some subclinical axons have crossed the neuroma and have reached the muscle, making it not electrically dead. And in this condition, there is probably a good reason to do a nerve surgery. If one does not find good fibrillation, then for certain the nerve surgery time is over and one should do something else.
Yeah, and here we will rely on the EMG.
The good EMG to see whether there is good fibrillation in the target muscles or not.
Dr. Yasser, have you any different strategy or something else to add?
For these patients, I think I'll go a little bit classic because I'm not sure by the results of the EMG. As Dr. Sharif says, that it's important that the muscles should be firing, otherwise the nerve transfers will be not successful. So I'm a little bit worried about the results of the EMG. I go classic. I guard against any contractures, and this is through, if it comes with contractures, this will be a little problem. I'm going to use braces to correct the contractures. If there's no improvement by the braces to correct the contractures, then I can consider proximal subscapularis release posteriorly and put him in a brace and continue rehabilitation until he reaches the appropriate age of tendon transfer, which is according to the size of the patient, the baby, and his intelligence. But it begins from 2 or 2.5 years. Then I go for transfer. Here, the transfers may be two types of transfers. Sometimes they don't have any rotators and they have no deltoid or a very weak deltoid. So in these conditions, in addition to the Hoover technique, which we do for rotator cuff, we can consider transfer of the trapezius muscle for the deltoid. And I remember one of the research papers of Dr. Gilbert that in non-improved patients after microsurgery, he uses the technique of trapezius transfer to the deltoid. So I will go classic for this patient, guard against any contractures by therapy program or even surgical release. Wait until the patient is old enough to evaluate his function and his intelligence to plan reconstruction by muscle transfer, either only for the rotator cuff by Hoover technique or maybe Hoover plus trapezius transfer.
Thank you, Dr. Yasser. This is also one of your the patients that were in your presentation, sir. This is an old patient with a head deformity. There are a lot of questions in our inquiry tonight about the timing of the derotation of osteotomy, and is there any contraindication to do it? And if such a condition could be changed into a tendon transfer that can give a good function as we saw in your patient?
This patient is very puzzling. That's why I'm trying to present now. I don't have a perfect solution for him. And maybe now after the presentations of Dr. I think this patient, for better planning, we should have done PSI to have a plan. But for me, for this patient, I knew that, first of all, as long as he does not have any cortical or chromium changes and the head is deformed, then I should correct it by a derotation osteotomy from the start, because of the internal tissue will be corrected without an osteotomy, and then plan him later on for tendon transfer. The point here is that does corrective osteotomy, derotation osteotomy, a definitive procedure for patients? I believe no, because whenever you do an osteotomy and there's no rebalance of the muscles, then there is a recurrence. So the patient, first of all, had internal rotation, and then you correct it to a neutral position, for example. Then the subluxation increases because the head tries to set a position of the neutral position of the arm, forearm, so it's more subluxated. So the derotation osteotomy should be planned according to what you require. It's not a routine operation in Erbs palsy, because this was used to be used in our hospital maybe 20 years ago. So the role of osteotomy in these patients is only to correct the bony changes and then do a muscle transfer. This patient, for me, is a puzzle because the head here is very flat, the glenoid is also hypoplastic, and I just want to correct the head in position and reconstruct the abduction. So I just want to raise if any one of the guests like to give us another way of treatment. For me, I did a corrective osteotomy and then a muscle transfer. Any opinion of Dr. Bassem or Dr. Sharif?
Not really. No.
Yes, I would like to mention just one point, involving also including the arthroscopic treatment. Well, arthroscopy do actually two things: is release of the capsule and elongation of the subscapularis by cutting it obliquely and putting the patient in external rotation and leading it healing with fibrosis. So at the end, we have a longer subscapularis. That's one point which will help the external rotation. Another point which I really, from my experience, I see it very important, is that the inferior capsule, if it is contracted, it will push the head upwards, and this will also affect the elevation. And by releasing, if this is the case, by releasing the inferior capsule, you can resettle the head more anteriorly and inferiorly. And you have also the capsule longer. I am now also thinking that beside doing that, in these cases, I would do the superior capsule cruciate reefing. So I have from above pushing the head down, releasing the capsule inferiorly, and elongating the subscapularis. And this are interventions also done arthroscopically. It's one-day surgery, and we may have a good result from that.
Do you have a contraindication for
Yes,
the osteopathy?
Ayman, Dr. Ayman, have one comment on
Yes,
this topic.
Yes. Doctor.
Yes, one should determine the level and the presence where the contractures are before planning the surgery. And this is done by returning the body of the scapula to its normal position compared to the other side and seeing where the arm is present. So in the presence of superior contraction, one would find the arm abducted.
Abducted, yes,
And
true.
if in the presence of inferior contraction, one cannot do abduction, particularly if the acromion is not elongated and going down.
Yes.
In the presence of internal rotation contraction or external rotation contraction, one should identify the contracted elements, because releasing everything is not probably the best thing to do. One should only focus on recovering the passive range of motion, and whether one would need tendon transfer. This could be done even at a later procedure, not immediately on the same on the same session, because if the contracture is released, one does not know what are the muscles that act in the opposite direction would do, because the muscles would not act in the presence of a fixed contracture.
Yeah, and Dr. Sharif, to summarize up, what are the contraindications for such what's presumed a simple procedure?
The tool to do the surgery is not an important detail. The important detail is what to do in the surgery. So one should first try to find, if there is superior contracture, then the deltoid is short, and one should probably follow the advice of Dr. Lambert about it, or release part of it even. If there is a contracture at the inferior contracture, then one should not recover abduction without releasing it. And as an anterior contracture is more difficult to release, because sometimes releasing the subscapularis leaves the muscle in a weak condition. So one loses the internal rotation power that is mainly supplied by the subscapularis. This is not a very easy procedure. However, releasing only the contractures and evaluating the patients later on for possible tendon transfer is a good option.
Thank you, Dr. Sharif. I think our time is running out. By the end, we have to thank you all, our panelists today. We missed Dr. Alex from Spain. I wish him to get well soon. Thank you for Dr. Simon Lambert from UK. Thank you, Dr. Sharif, for the nice presentation and the discussion. Dr. Yasser Safouri, our Vice President, and Dr. Basil Flega, the President of the Association. Thank you all, the audience and the participant for tonight. See you soon, inshallah, in coming events. Thank you. Thank you, Dr. Yasser. Thank you, Dr. Basim. Thank you, Dr. Sharif.
Thank
We
you.
want also to thank the sponsor of this webinar, Novartis Company, which is a friend of our society now. And we want to announce for the coming webinar, it will be on the first Friday of next month, November, the 6th of November, and it will be on elbow trauma, and all of you are invited. Thank you very much.